in the beginning?
Well, it's not 10 o'clock yet, so they haven't streamed in droves yet.
Yes, that's right. They will.
Okay, that's
Don't
fine.
be nervous.
Cool.
And you're going with car.
Yep.
Okay.
Much easier. Yeah.
What's your name? Your son's 5 already. Did he does one before? Whenever you're ready. Should we go? Good morning, everyone. Welcome back. I'm so pleased to have Dr. Jessie Carr with me today. Jessie Carr is an epidemiologist at the Minnesota Department of Health, where she leads the environmental health tracking and biomonitoring programs. Her team works across MDH and with state, local, and tribal partners to generate actionable and relevant data, science, and stories connecting environmental exposures, inequities, and health. Jessie received her MPH in Environmental Health Policy from the Mailman School of Public Health at Columbia and a DRPH in Environmental Epidemiology and Exposure Science from Pittsburgh, where her training focused on the intersection of social environmental epidemiology and exposure assessment methods for environmental health disparities. She's so cool. This is actually how I know Jessie. Our work overlaps in those ways, and I serve on an advisory panel for her unit and the important work that they do, which is actually, I don't know if everyone realizes this, but your unit's work is legislatively mandated. Yep, they are in existence. Her position is in existence because our state legislature believes in its impact. As importantly, Jessie lives in South Minneapolis with her son and loves spending time exploring the Mississippi River Gorge and baking chocolatey treats. So for those of you who are on Zoom and not here, well, I was just going to tease you that you're missing out that she had baked for us, but not today, another day. So welcome, Jessie. And Jessie's here actually not to speak in her capacity as the unit director, but rather on an overarching MDH initiative. So she's here to speak to us about data vision and the roadmap project and its overview. Welcome, Jessie.
Thank you so much, Ruby. I am so pleased to be here. I really, it's one of the pleasures of my job is that I get to work with so many people across the agency and local public health, and most of the time kind of really serve as a connector. And one of those spaces that I feel like wanting to be more connected with is with you all at the university. And so I'm really happy to be here and really excited to share what we're doing. We are midstream, so this is, we're doing this as we go, and so really looking forward to hearing your perspectives, honestly and critically of the state. As Ruby said, my role at the state, I work a lot with data and helping to kind of translate a lot of the enforcement, messy environmental health data that we collect in all different forms, and translate it into surveillance data that people can use to track trends over space and time. So I get to work across the agency. And during COVID, I was reassigned to help coordinate data initiatives across the agency and with a range of external partners. So again, serving in this role as connecting around data, which at the state is really our core function. Minnesota is a little bit unique in our public health system, is a partnership between state, local, and tribal. Some other states have a public health system where the state health department is much bigger and has regional offices or something like that. But in Minnesota, we have, each county has a health department, or most of the counties. We have a lot of counties, a lot of local health departments, and they are really the ones doing the critical public health practice with communities, with partners, engaging, with all of us. And so data and making sure that our partners have the data that they need to fulfill their work is really one of our core responsibilities, and one that we have not done well over many years for lots of reasons. And so this project is starting into the slides, and so I'm going to give a little bit of background on the project, our structure, our methods, because I know that you all will care about that. And then talk about like where we're at, some of the things that the goals and guiding principles that we have set. And then the next phase, which is going to be asking that question of how do we actually do this? This is a big initiative. And I will just warn you that these slides are not following kind of best practice for PowerPoint to have few words and, graphic. And there's a reason for that. The reason is that we know that this is going to be recorded. This information, we want it to be shared widely. Lots of people take in information in different ways. So we really are, there are a lot of words on the slides. You can read them or not. I will, I'll talk through the important things, but that's the reason is because this information, we want it to be shared broadly. And so we really want it to be the full meaning to be captured in the slide. So as I said, data is something that we have not seen as we have not really treated effectively, as effectively as we could as a service. And there's a lot of, reasons for that: capacity, statutory limitations on our authority to share data, privacy protections, all of these things that are really important. But still within that, we hear for decades from communities, from partners, probably from you all, about frustrations about not being able to get the data that they need from the state. And particularly important around collecting meaningful data. For example, having information on disaggregated race ethnicity has been a core ask from communities. I think the first time MDH wrote a paper on it was in 2011. In 2014 or 15, the Department of Health affirmed our commitment to doing that in an advancing health equity report that identified structural racism as a fundamental cause of public health outcomes and disparities, but we still, are not doing it consistently across the agency. So COVID really pushed us forward in both in technology innovations, but also and investments, frankly, from the federal government, as well as really breaking down silos. We're working much more closely with community than we ever have, or I would say there's lots of parts of the agency that do work very closely with community, but kind of scaled up for the urgency of the pandemic. And so it really motivated us to keep going with that momentum and see how that we could address some big systems changes with and transform how we do data across the public health system. So as I said, we are not currently meeting all the needs of even our internal programs, as well as all of the partners with research, healthcare, local public health, tribes. And so this vision is really trying to build a data system that's relevant and responsive with a focus on advancing health equity with data. The discrete goals of this project were to gather broad input to create a data vision and roadmap for how we will achieve that vision. We know that if we have just a top-down approach to systems, a top-down approach doesn't really work for systems change. You need to have the commitment and buy-in of leadership, but we are explicitly taking a really participatory process in this project that I'll talk about, because we need it to work for staff on the ground. We need it to work for the folks who are doing, who in local public health who need to share and receive data. And we need it to be sustained longer than, politically appointed leaders. So our structure, when we got started in earnest on this project about a year ago. We created, we knew that we needed to have, this is a big ask. So we created an advisory committee, and that consists of MDH staff and community members. Those staff, applied and we had a process, and we are compensating community members. So these are folks from nonprofit organizations who have really been in these discussions with us for quite a long time. For example, we have someone from the Council of Asian American Leaders. We have an IT specialist from Family Tree Clinic, and somebody from the University of Minnesota, Linda, who works at the, it's such a long name of the center where she works. It's for translational, CTSI. Yes, CTSI. So it's been really, really fun. It's a wonderful group of diverse staff from all across the agency. Part of our goal was to not have kind of the usual suspects like me, frankly, who are always in data discussions. So we have folks from our community liaison office, we have evaluators, and others who have a lot of different perspectives on data. We have a leadership committee to help with problem solving and alignment with all of the other initiatives that are going on. So that's one of the ways that we keep aligned with, this is not the only data initiative going on at the agency, but really seeking to string them together and provide undergird them with a strong foundation in health equity. We, for the project values, again, I've kind of alluded to this, but we're really trying to do this project in a different way so that we have a different outcome and don't end up with a report that goes in a drawer. We're trying to leverage our strengths and humbly acknowledge the gaps and limitations in our agency, prioritizing the well-being of our staff and partners, recognizing that we're still in this pandemic, and that the lack of and the misuse of data can be traumatizing and stigmatizing. We're taking a trauma-informed approach and just really communicating and being as transparent, just over communicating 3 times more than we think we're supposed to, and being really transparent about our processes, and really looking to build trust and ownership in this work and explicitly challenge the historical legacy of oppression in data. This is kind of our process where we've been. We started with an initial framework that the advisory committee then refined and added some guiding principles that I'll talk about. In the November, December of last year, we hosted a dialogue process that we're calling this. So to get feedback on that vision and revise it with external partners and staff as well. And now we're in the process. We've incorporated that feedback. I'm going to share that with you today. And then now we're planning for the next phases where we're going to have a second dialogue process about gathering feedback about implementation steps and priorities. So some of the methods for where we've been so far for that dialogue process. We, as I said, we had facilitated listening sessions. They were all virtual, as well as an online survey. We put together kind of a host your own dialogue toolkit for existing small groups and communities of practice, that they could host it and submit their feedback that way. For all of the sessions, actually, this is the first session. This is the first time we're really talking. We've done some recorded webinars and question and answers, but we have had all of our feedback sessions have been totally anonymous with no RSVP, no recording, so that people would really feel comfortable to give honest feedback. We know there's a trade-off there because we don't know exactly who's participating, but we felt like it was worth it. All of our questions have been really the same in this, asking, what caught people's attention, what it got right, what was missing, what could be improved. For the listening sessions, we had a short video that was introducing the draft vision. We had a facilitator's guide, and we had note takers for each session. We had 6 internal sessions that were organized in kind of topical areas around data collection, data analysis, interoperability, which is more of the technology side of it, and communications. And then we had 6 external sessions that were more organized by sector, where with local public health, academia and research, healthcare systems, and broader community sessions. And then that's, in addition to that, we did a number of kind of focused engagement with community liaison groups and within the Department of Health and our Health Equity Advisory Council, Leadership Council. So we had over 100 people, and that number is low. I think it was more than that, but where we had, among the people who did complete the evaluation form, 96% said that they agreed that the dialogue process did a good job of capturing their feedback. The online survey was similarly structured by these broad topics, and had a similarly kind of strong response about how well their feedback was captured during the session, or through the survey rather. So this is more internal, but this is the same actually. I can skip this one. So to incorporate that feedback, we use the notes from the feedback sessions and the survey. We sorted them by focus area and kind of paired off and analyzed it, came back and shared. We took kind of a thematic analysis approach, and then incorporated the revisions to the draft. We recently, just a few weeks ago, launched the revised vision with an internal and external webinars, and have some updated materials. And we again launched another online survey to get feedback, to ask how well people thought we had done in incorporating their feedback. So far, we've only had 36 respondents, but the feedback, we have more than a good majority saying that their feedback was incorporated very well or somewhat. And reactions to the vision overall are around 70% loving it or liking it, and 19% having some reservations. That's pretty balanced between staff and external partners who filled out that survey. This is still a small number though, but the point is that we're just trying to gather feedback at each step and then ask again, how did we do? So that's where we are. Now I'm going to go into just going through the vision. Like I said, there's a lot of words on these slides. I think I'm going to read them, and we'll still have time. I have about, I'm more than halfway done, so we'll have time for questions, but you can read them yourself or follow along with my voice. So the vision statement, I guess, which is not a draft anymore, to complement our agency mission, is that our public health system supports strategic goals and advances health equity through the consistent, transparent, timely, and equity-driven collection, interpretation, use, and sharing of data. I'm sorry, these slides got combined from another one. So guiding principles, we did not start this project with these, and the advisory committee developed these. These are principles that are designed to guide our work and the people, even as our strategies change, as our priorities change, These principles set a standard for the mindsets and attitudes and behaviors within MDH when it comes to data. And because one of the things that is like foundational assumption of this project is that the challenges that we face regarding data are most often related to our norms, our culture, our assumptions, our risk assessment, and our values, rather than, I mean, there are certainly technology issues, but primarily it's around our decision-making and our values. And so these are 12 guiding principles that were set out by the advisory committee to really, like it says, be able to guide our decision-making no matter what kind of project we're working on. So here's where it's a lot of words. So I'll just start reading them. So we recognize that structural racism has impacted MDH's historical approach to collecting, using, and sharing public health data, and this has caused harm to Black, Indigenous, and people of color. Minnesotans come from a variety of cultures and backgrounds, and they bring different ways of knowing, all of which are valuable, including cultural knowledge, community wisdom, lived experience, and institutional knowledge. And that we acknowledge that we perpetuate structural racism and other institutional systems of oppression when we assume there is only one way to answer a question or only one right way to answer. Health disparities have multiple causes, including historical and current racism, systems of oppression, and the resulting generational trauma experienced by marginalized communities. When we collect, analyze, or share data about health disparities without this acknowledgement, we risk further stigmatizing communities and perpetuating harmful stereotypes. Disability is a natural part of the human experience. It's important to collect and share data that can illuminate and help us address health disparities experienced by people with disabilities. People are more than just one part of their identity, and the intersections of our many attributes like race, ethnicity, age, disability, gender identity, or location can have important implications for Minnesotans' health. Data must be looked at through an intersectional lens to identify and address health inequities and to draw attention to groups that have been historically marginalized. The way that we collect, interpret, use, and share data is shaped by organizational history, cultural lenses, and people's individual experiences. We need to bring a critical and multicultural lens to how we make decisions about data and what is informing those decisions. Centering health outcomes for groups with societal power and privilege as ideal or normal perpetuates analytic frameworks and continues practices that drive inequities. Tribes are sovereign nations, and the government-to-government relationship between the state and tribal nations outline additional data sovereignty, collection, sharing, reporting, and communication requirements. And I just will note there that we are kind of having a really like parallel process with tribes, not in a formal consultation process, but recognizing that they're, like I said, they're just different parameters of that relationship. And so we've been working with tribal health directors and other folks kind of to co-develop these priorities with them. Minnesota's public health system is a partnership of state, local, tribal health departments that depend on access to and ability to make meaning of timely, high quality, and locally relevant data. Intentionally and securely expanding data access and sharing systems internally and externally is critical for meeting public health challenges of the 21st century. Transparent and consistent data standards or standards for data collection, use, and sharing are necessary for building trust and more effectively serving all Minnesotans. And lastly, how we communicate about data can be just as or more important than what we communicate, especially with and about communities most impacted by health disparities. So that was a lot and reflects a lot of feedback from many, many people. And I'm grateful for all of their input. So for the next part of the vision I'm going to share with you are the goals. So we have kind of 5 areas. It's too big to have an overarching thing. So we have 5 focus areas. And so I'm going to share what are the goals and then some examples of what achieving that goal might look like. again, the next step of the project is really hammering those implementation steps out and making the priorities. So these are the 5 focus areas. So the draft goal, or this is now revised, this goal, it's going to be an iterative process. This is going to be, like, we're never going to say this is like final and lock it in. So I guess it's fine. It says draft goal. So together with communities, partners, local public health, and tribal nations, MDH will develop straightforward, transparent, and consistent ways for how it will collect and protect data going forward. This seems obvious, but there are lots of areas where either, where we have standards, but we're not transparent about them, and meaning that those standards are freely available or consistently implemented. We are, there are MDHs alone. We collect hundreds of different data sets. We receive more data sets from partners in healthcare, and starting with the standards for how the data that we collect and receive is one way that we can kind of make sure that that we are walking this talk, as we don't have control over lots of the data that we don't collect. Some of the data that we do collect are obviously like the Minnesota student survey, a lot of COVID data, infectious disease data, tons of data that we collect, women, infant, and children program. And so some of the steps that I'll share with you that might achieve this vision are collaboratively identifying ways that data should be disaggregated to accurately identify and track health disparities. So this work is underway already with regard to disaggregated race and ethnicity categories, and they're planning on developing standardized data collection categories for disability status, preferred language, and sexual orientation and gender identity. Because if we're not all collecting it in the same way, then these things seem straightforward, but they're having a community engaged process to identify those categories with the folks that they represent is not normally how we do this work. So that the Center for Health Statistics is leading that work at Minnesota. For data analysis, we will make sure that all stages of the data analysis process are transparent, rigorous, and responsive to pressing questions about how to advance health equity. Right? We have so much data and we could do so much analysis. So how do we choose? How do we choose what questions we're going to ask, what methods we're going to apply, and then how we share that. A lot of that, a lot of the analysis that we do is mandated to meet federal statutory funder requirements. How do we ensure that we're also responding to the pressing questions of communities? One of the ways that is already underway that will be expanding is creation of data liaison roles for various focus communities that are really serving as a bridge to respond to requests and consult on the interpretation of results, moving towards developing an equity, like a research or a surveillance agenda, I should say. We don't do a ton of research, but what are the things that we're gonna systematically track routinely? So we look to you all to help us with kind of focused studies, and then how do we do this work on a routine basis and look whether it's to track disparities or whatever else it is. For data communication and reporting, the goal is that we will talk about and share data with others in ways that elevate health equity and enable people to easily understand data. This work of translating data, visualizing it into plain language concepts is very challenging, as you all know, and not something that we always do in culturally responsive ways. So some of the steps are taking there is to like one of the steps that was suggested was to create enforced decision-making criteria within MDH for sharing data that could be stigmatizing. So governance and access is a big one. When we say governance, that means the kind of the rules of the road for how do we decide what data are shared, how do we come up with this rule that fewer, 5 or fewer counts is, that violates privacy rules, but six case counts is okay to share, or something like that. So we have a lot of rules, not a lot of them are clear in how those decisions were made, why, and how they impact, how that, the underlying risk assumptions impact access to data, especially for as we move towards disaggregating data more, we're moving towards more situations where we have small numbers and potentially identifiable or stigmatizing results to share. So doing these things in tandem where we're considering the governance, privacy, and access, as well as we're trying to advance these other things, is really important. And then finally, data systems modernization. Our goal is that data systems and technology will continue to be modernized to deliver accurate data in the correct format to people who need it when they need it. This includes the systems and technology within MDH and those shared between MDH and our partners. So this is about the infrastructure, the technology, but also the decision making. How do we develop an equitable and strategic approach to updating our legacy databases? We still have some databases that are receiving faxes. I think the public health system has been underfunded for decades, and some of our critical databases, for example, can't accept text strings, other than like an address field or something like that. So we can't accept qualitative data, as an example. Some of the questions, so those goals are broad, and the work that we're in now is about making them concrete and how we achieve them. A couple of the questions that we've gotten along the way are like, really, these goals are so broad and they are so focused on our partnerships, like who is this for? So this is a vision for MDH, but we're doing this process in a participatory way with our partners because we can't do our work well without your input. So this is direct, we're not directing the work of others, but seeking input to do our work better. How will we use this vision? This vision is already being used to, for example, develop our strategic plan for the next 3 years. It's being used to prioritize and guide critical technology and systems transformation. It will be used to provide partners with clear expectations so that we can work collaboratively and be held accountable for making the changes that we've been hearing for years. None of this alters our ethical or statutory obligations around privacy. And like I said, it doesn't stand alone. And there's a lot of good work going on in the agency. So this is building on strengths as well as deficits. So in the next stage of the process, we will be probably in May, we will be holding listening sessions, again, launching an online survey and having small group discussions, and consider this a pre-invitation to please participate with us and tell us what you think. You can tell me today. So I'm just showing this again, and that feedback process will begin. And what we are right now developing a draft roadmap that has in it all of the implementation steps that, some of those examples that were on the slides, as well as others that we've heard across cross-cutting themes around capacity building, around strengthening the public health system, around transparency and decision-making, and other themes. And so we're going to be doing that. It also includes draft performance measures, resources needed, and the other details that will actually help us ensure we're getting the work done. So it's we're almost halfway through with time, and so I'm so interested to hear from you all how these how some of these themes and questions and challenges are how you're having similar questions in your work around how you do study design, reporting of results, considering around health disparities and thinking about stigmatizing and how you're doing that work. And I know that I think that you all have opportunities to really be leading in some of those spaces. And so I look forward to hearing your suggestions for us, but also learning from the ways in which you all are thinking about and leading in this space of what do they say? Public health of consequence, right? So that's, and specifically, if you have also thoughts about strengthening those data relationships between the university and health, how do we develop a workforce that is better able to answer, these methodological and communications challenges. Anyway, those are big questions, but that was a lot to digest, but I can see the chat too. So happy to open it up.
Thank you so much, Jessie. So I do invite the people on Zoom to either unmute and ask their question or just write it in the chat. But surely Jessie had come to us. I should have said this in the introduction, but Jessie had come to us particularly for that first bulleted question, which was really from our point of view, from our side of the street. What conversations are we having? And then how can we possibly, merge our ideas and our missions to maximize their work as well. So Jessie purposefully came over across the street, so I appreciate that very much. Questions for Jessie?
This doesn't get at any of your questions, but hi, I'm Katie Berry. I'm a PhD student here in the epidemiology division. First of all, thanks for coming to visit us. Enjoyed your presentation. I really appreciate MDH's attention and dedication to health equity, and also the transparency you guys are showing by sort of coming and telling us about this process. And I thought that the guiding principles that your advisory board came up with were really clear and well articulated. And so it's really interesting to hear about this process and this sort of like big picture thing. But I feel like a lot of us are better with specifics in the concrete, and like maybe we're getting way ahead of ourselves here. But could you provide some examples of sort of like a problem that existed before that this vision will help solve, like a local public health community, local public health workers having trouble collecting data on X for Y reasons, and the data vision is going to help with that because of Z.
Sure.
And also maybe an example of from like the data access side of like once the data is collected.
Sure, and I think that response has been widely felt over the past, 9 months or so, because, and I'll just say that we felt strongly that we needed to get on the same page about the big picture stuff first, especially because we find, and I find in my work, that when, and you all probably do too, that when we talk about health equity, we might think we're on the same page, but we're not always on the same page. And so that is why we have put a lot of this time into like definitions and big picture thinking. But people are ready to go, like with the, and to give us concrete suggestions and provide concrete examples of where things haven't worked. So one example, so about how this vision, so there is lots of, as you know, like innovation can kind of flourish and advance when it's like in a small pocket and you can push it forward. So part of what this vision is trying to do is like, how do we make that consistent and scale it up and learn from each other in a better way? So an example of that would be, I guess I'll just stay on disaggregated race ethnicity data. It was really a huge demand during the height and of the COVID pandemic. We were seeing, I mean, as you all know, really high and disparate rates across Indigenous, Black, people of color. And for example, without being able to disaggregate data, we were really not able to target our resources in a timely and effective way. So for example, we were seeing where we were, if you follow the federal ONB 15 categories for race ethnicity, you have, Asian, Black, and then a separate, ethnicity category. There's no way to, accounting for multiracial, multi-ethnic people. We saw there were wide disparities, for example, within the Asian community. Very, when we started to disaggregate the data by race and ethnicity, and we had to do it in phases, right? Because we didn't even, we were collecting data on REDCap. I don't know if you all use, REDCap, and we were using pretty coarse things with contact tracers who, some of them had never collected data like that. They were, some people were uncomfortable asking people questions about their racial identity or about their sexual orientation and gender identity. So we were getting really, really disparate data quality. So one of the things that we're like taking from that experience and lifting up in this vision is, okay, thinking about it from all these different angles. How do we ensure that our technology is set up to accept, the disaggregated race ethnicity fields? And so we've done that. We ended up, the Minnesota Immunization Information System ended up making a really innovative partnership with health systems for electronic health records, where we were able to get the authority to link. Previously, MDH didn't have the statutory authority to even collect race and ethnicity information about immunizations, any immunizations. We in Minnesota, I don't know if you're aware, have some of the strictest privacy and like data. We have a lot of the ways the authorities for what we can collect data for are statutory in statute, and that's different from some other states. Some other states defer more authority to the Commissioner of Health. So we were able to make a partnership with the environmental to get electronic health records and link those to get more demographic information about, for folks, so that we could better understand both geographically and through cultural identity. So that was like a technology piece of it. There was a training piece of it where we really did more focused training and evaluation around data collection through contact tracers and interviewers. And then more communicating out about that data and having it more on a routine way impact how we were distributing vaccine resources and testing resources. We did not, so it took, there was, and we were not disaggregating data, our COVID death data, for example, by race ethnicity. And so we were missing, we weren't not seeing the elevated death rates in the Hmong community, for example, compared to other Asian folks. And so we had this lag time in our response where we were not, we were, as I think they were saying, we were building the plane as we were flying it. And so this vision is trying to say, okay, what were those ways that we did it, and how do we systematize those and build those out? In terms of like data access, we, I don't know if you've ever requested data from the Department of Health. We do not have like a central door. So you generally have to know which program to contact, and it's the access can be on an ad hoc, basis where programs have to make decisions about what they can stay out. And that's the reason for that, is that we have so much statutory variability across programs. And for example, you would have, the sharing authority is very different for our cancer registry as compared to other data. And so we were able to create, at least for local public health, a secure server where they would have direct and timely access to data for their jurisdiction, so that they could have that data in a more timely way and not have to do disparate data requests for other people. And so those are things that we are trying to scale up.
Super helpful examples. Thank you.
Any other questions for Jessie? Jessie, do you have any other questions for us? How can we, maybe one question is, how can we stay involved in this process or follow the process?
Sure. So we have, I will send some follow-up email where we have you can sign up, opt in to getting updates on the project. We have a SharePoint site where you can follow along. You can follow the site and get updates. Like I said, in May, we will be scheduling at least one facilitated listening session that's specifically for partners in the research and academia space, really wanting to learn from you. We're being asked to, in applied public health, we don't often have a use case for doing mixed method, multi-level, nonlinear regression, because how do we then explain that to, our communities? And is that the most useful, right? So we are in a place where we are really trying to advance our methods to do intersectional analysis, to do better small numbers, small area analysis. And a lot of your alumni from your program are the ones who are doing that at the Department of Health. And I learn from them, and I'm so grateful. But as we get further away from our training, I finished my training, more than a year ago. And at the time, I thought I think I was pretty steeped in small area analysis and GIS, and now it's all past, so while we at the state might not be doing those like cutting edge, Bayesian analyses, how can we work with you to help us understand how we can apply the, up-to-date methods in a way that works in an applied setting, and how can we learn from you all? Like, I think that the U has really put it, at least from what I didn't go here, but like I really respect the attention to engaging with communities and like your research participants, and not treating them as subjects. And how can we learn from some of those methods about communicating and sharing ownership of data that you all really have kind of a luxury to deeply explore, and do so well. I mean, like I'm most familiar with Ruby's work, but like really so much care put into that. And how can we better learn from you about how to collect meaningful data and report it back in ways that are meaningful.
For example, something that come up, and it actually has come up in the curriculum conversations, is COVID modeling. modeling skills needed,
Mhm.
that were used during COVID. And if there were ways for our curriculum to better inform our students who would ultimately end up in positions like yours at MDH to have those skills. But having said that's slightly off topic, so I apologize. I actually do have a question with regards to race and ethnicity disaggregation. So one of the biggest concerns is, I'm working toward this with the Asian data. One of the biggest concerns that I repeatedly hear is that there really isn't enough power to examine some of the smaller Asian Asian ethnicities. Of course, in analysis, that's true. So my question is this. When you were speaking today, you were speaking about data collection. There's also this other component of what you do with the data once you have it. And so if there are too few Tibetan Asians who are represented in the COVID database, what ultimately can be done? So what I didn't hear is like a discussion at MDH about that other part. How best to make the decisions about analyses once you have all this data. And of course, best practice is to collect more data than you could possibly use, right? Without burdening the people. But so better to have the ethnicity data than not to have it and not be able to use it. But really there is that other component about analysis. So for example, in some of my analysis, this is only relating to the Asian market. I've been doing it by region of the world. So for example, Southeast Asian communities tend to have track together, regardless if they are Thai or Vietnamese or Lao. So, and we'll see those overlaps in everyday life with Southeast Asian. So in one way that I organize, and actually Isabel's working on some of these papers as well, is by region or immigration status or some other variable. So that's my question. Can you speak at all about that second process? What do you plan to do with all the data?
Yeah, 100%. And so I think, and then there's also the question of what are we not going to collect? Like we've made the decision, we have made the decision that we are going to collect this because we actually, if we don't collect it, we don't know. I mean, we think the numbers are too small, but so at the Center for Health Statistics, they've been taking an approach with this question of trying to provide and create kind of a flexible scaffolding, kind of like you said, about what are kind of intermediate aggregation schemes that could be used, and based on the research question or the surveillance question or topic, how might they choose? And so one of them, I think one of the ones that they're working with is that, like that kind of similar frame that you're talking about regional. And so, I mean, so the goal that the Center for Health Statistics is that they want to make those decisions around we need to have like standard guidance for analysis that's flexible enough for multiple different sample sizes and questions to be able to apply it in different ways, and make sure that those kind of those intermediate aggregation schemes resonate with communities. So what they've been doing at the Center for Health Statistics is they've been hosting what they've been calling town halls. And it's kind of a similar thing with disability status, right? So like, how do we, right? I mean, there are not even in hospital records, like there are really not very articulated categories of disability status. And so working with different communities to figure out, okay, what's the finest level of data that we're going to collect, and then how do we so at the Center for Health Statistics, they're trying to do that in a way that create a guidance framework for the agency that is resonant with the folks that the data represents. And then I think that part of it is a trade-off for having to wait until we get multiple years of data and something like the student survey. where we know, especially for those mechanisms where we are, or instruments that we're collecting data on a regular basis, what is, if we have to aggregate 10 years of data together, is that useful? You know, like, I don't know. But also, I think that they are trying to take a perspective of maybe we're not the end arbiter of what constitutes meaningful use. Maybe if there is a community that's requesting data about themselves, then as long as we're not violating privacy concerns, then, you know, how do we share that data in a way that other people can make meaning of it, and that we're not the, you know, we're upholding our statutory responsibilities, but not the sole determiner of what makes meaning.
Well, if there are no other questions, I want to thank you, Jesse, so much for coming across the street, and we look forward to being in touch in the future. And if you want to advertise to us again, the May forum for people like us, I'd be happy to distribute it for you. So
Okay.
thank you, Jesse.
Wonderful. Thank you for having me.